Hi, everybody. I instead of doing a written piece today, I'm gonna do a video format more so I can try this format out for maybe future content. But thanks so much for tuning in and for your interest. So today we're gonna review a presentation that I've prepared actually for the Stanford OBGYN residents that is basically about the fears surrounding prescribing hormone therapy, where that comes from, reviewing some of the data of the Women's Health Initiative study, and then we're really going to go into the details of what that study actually said and what it didn't say, maybe more importantly. Also, we're going to review some of the big topics from there. But my goal is that by the end of this, people who are watching don't feel afraid of hormone therapy. The presentation is obviously primarily intended towards a clinical audience. So, certainly if you are a prescriber, if you're learning this, hopefully this will be helpful. But I also hope that even if you're not a clinician, that you will have still a lot of takeaways, because I think that it's really important to know where we're actually coming from with our data and why this fear exists in the first place. So, why don't we get started? All right, so here's our presentation: Hormone Replacement Overcoming Fear and Headlines. My disclosure is that I would say in general, I tend to lean more towards the liberal side of HRT prescribing. I don't have a lot of fears with using hormone therapy. And my genuine belief is that everyone should be allowed to have the conversation surrounding hormone therapy. There are certainly situations where it might be more risky, and those risks may outweigh the benefits, in my opinion. But I think that at the end of the day, it's your body, and you should be the one who is making an informed decision of how you want to use really any medication or hormone that is going to go into your body or not. So, our agenda, we're going to go through some of the history of the use of hormone therapy and how we've regarded menopause. The Women's Health Initiative study is going to be the crux of what we're going to talk about. And then we're going to talk about the three big risk areas that people are always afraid of with the use of hormone therapy, which is cardiac risk, VTE or clot risk, and breast cancer risk. So, if you're a prescriber who is new to hormone therapy, I want this to be burned into your mind, which is that the vast majority of people do really great with exactly this prescription, which is a low to medium dose of an estradiol patch, 100 to 200 milligrams of nightly oral micronized progesterone, and then vaginal estrogen twice weekly for the rest of your life. The vaginal estrogen, 100% should be continued forever. I think that the other systemic hormones also should be continued forever unless a very clear contraindication develops. But obviously, that's maybe a little bit more of a discussion. But the vaginal estrogen, there's truly no reason to be afraid of that. With that in mind, we're going to talk mainly about systemic estrogen and progesterone today, but it's important just to say the vaginal estrogen is extremely safe. What I always say to my patients is that vaginal estrogen is safer than taking an ibuprofen or a Tylenol. It's not associated with any increased risk of cancers, clot, cardiovascular disease, no long-term health consequences, only positive benefits. Does not require a progestogen use at the same time. This is a common confusion. And maybe if you want to be the absolute most conservative, you should have some mild caution in people with a history of uterine sarcomas, which are highly sensitive to estrogen and tend to recur at the vaginal cuff after surgical resection, and advanced stage endometrial cancers, which again are very sensitive to estrogen and tend to recur in the vaginal cuff area. But even in those situations, I think it's very appropriate to still use and consider vaginal hormones, particularly if you are limiting that to vulvar use, which is often where people derive the most benefit. So, generally, I think the way that we should always be thinking about the fear of hormone therapy is if you're a clinician and you would feel comfortable prescribing an oral contraceptive to somebody, across the board, the physiologic hormone replacement therapy that we use for menopause is safer than an oral contraceptive. So if you would feel comfortable prescribing that, you should have literally zero concern or thoughts directed towards the fears surrounding hormone therapy. The other thing that's really important here is that it's really important the language that we use. So a lot of people will just colloquially use the word estrogens, but there's actually a lot of different things that that could mean. So when people say estrogen, it really is just a generic term that encompasses all of the compounds that exist in the world that can stimulate an estrogen receptor. So when we're talking about hormone therapy, These days, most commonly what we're talking about is estradiol. So estradiol is a form of natural estrogen that your body makes. It is the most active form of estrogen that exists. There's also estrone, estriol that are a little bit less potent or manifest in different ways in the body. But estradiol is usually what we're talking about when we're talking about hormone replacement therapy. Conjugated equine estrogens is another important term that we should review here because it comes up a lot in the past in old therapies. But for example, today we still use conjugated estrogens in the form of the medication Duave, which I won't get into in a lot of detail now, but that's a combination of conjugated estrogens and bazodoxifene, which is a SERM medication. But these are types of estrogens that are not physiologic to humans. They're not synthetic, meaning that they're not created in a lab. They actually are physiologic to horses, and that's where we derive them from, is from horse urine. The word Premarin is the brand name for conjugated equine estrogens, and it literally stands for pregnant mare urine. Ethinyl estradiol, on the other hand, is a synthetic estrogen. So this is a type of estradiol that synthetically in a lab has had a 17 alpha ethinyl group added to it that prevents it from being degraded in the liver. And the reason why this is important is that this makes it 100 times more potent than natural estradiol. And the benefit of that is that we use it in contraception most potently to help control bleeding as a side effect of the use of contraception. But it's important to say that this is not a quote unquote natural physiologic estrogen. This is a synthetic estrogen compound that has its own benefits and its own risks that are different than what we would use for hormone therapy. Similarly, on the progesterone side of things, a progestogen is the category of compounds that stimulate progesterone receptors. And then we can divide that into physiologic natural progesterone, which is most often what we use in the form of hormone therapy after menopause. So this is micronized physiologic progesterone, identical to human progesterone. Then there's progestins, and these are again synthetic compounds that are going to stimulate progesterone receptors, but they actually are derived often from other chemicals. So, like testosterone, a lot of progestins are derived from testosterone. We'll see on the next slide other ways that we get progestins. But the reason why this is important is because they're usually significantly more potent than natural progesterone, which is why we use them often for contraception or for bleeding control. But they also can stimulate other receptors in the body. So this might be androgen receptors. This might even be estrogen receptors. This might be glucocorticoid receptors. So there's a lot of different other receptors that are affected by progestins. It's not just uniquely the progesterone. And because of this, they have other potential risks or other effects associated with them that may be good or bad. So here you can see medroxyprogesterone acetate is a common progestin that was used in the past, in particular for hormone therapy, and we'll talk about why that's important. That is derived from progesterone, but you can see that it's a different chemical compound. We don't really use these ones as much, at least in the United States. Norethindrone acetate, levonorgestrel, these are other common progestins that are used in contraception or for bleeding control, particularly in the case of norethindrone acetate. And here we can see that they're actually derived from testosterone, not from progesterone. And then drospirenone, or the brand name for that is Slind, it's also present in contraception like Yaz or Yasmin, is actually derived from spironolactone. And so this is going to be the one that has the most effect of blocking androgen receptors because of the way that it is derived from spironolactone, which is an anti-androgen medication. So let's get into our history a little bit. So, first of all, important introduction just to hormone replacement therapy in general is that it is the most effective treatment for menopause symptoms, better than any of the non hormonal options that exist. And I think this is just an important baseline to start from because a lot of people will go through prescribing and managing of menopause with the idea of, oh, we can kind of like work our way up to hormone therapy. But really, if you want to provide somebody with the best possible treatment for their menopause symptoms, there's nothing like hormone therapy that's going to do that. Also, a lot of the non-hormonal options really only work on hot flashes and to a lesser extent sleep, whereas hormone therapy is really working on all of the potential consequences that can come along with menopause. So how did we get to where we're at today? Everything started with Premarin. So again, Premarin is pregnant mare urine. So it is the conjugated equine estrogens. It was approved in 1942 for human use. In 1966, there was a book that was published called Feminine Forever, which was a largely, I would say, misogynistic book, at least in terms of modern ideas of how women should exist in society. But basically, it was sort of saying if you take Premarin